We are live. All right. We don't have a viewer at the moment.
That's okay. They'll probably yeah.
Yeah,
I think you
we are
have to
live.
post the stream on the group also. Do you have the
Yeah, it's
video,
it's
Bella? Because my sister was asking for it.
yeah, we are live now. So welcome to the session 2 of ZMC Alumni dialogue with our graduates, fellow graduates on COVID-19, the latest pandemic that's taking over the world. It's like the World War III. So our guests for today are Karim from batch 4 and Rizwan from batch 6. Both of them are in North America, and Karim is currently in Canada. And we did some introduction a little messed up in the email. He's currently director of infectious disease at Niagara Healthcare Center, if I'm correct, and he's also lead of the pandemic team and emergency team over there. And he's also in an academic position in McMaster University as assistant clinical professor infectious disease. And Rizwan is basically a diplomat, American board, and certified in neurology and specifying in stroke division. Welcome to both of you. And with me, Hoda will be starting the questions to both of the guests. So you can start
Yeah.
your questions, Hoda.
Thanks, guys.
Hi everyone. So Kareem, I would like to start with you and ask about the coronavirus itself. What exactly is it? How many strains are there? And how did we get where we are today?
So, first of all, thank you for letting me talk about this today. Um, and happy Doctors' Day to all of us. That's it's first May, Doctors' Day, and I really wish Dr. Irfan Ahmad Khan was here with us, and if he's looking at us, like I want to give out a shout out to him today about this. Okay, now this coronavirus has taken over our life over the past 3 months or so, right? And basically, what we know about coronavirus is um, it's a zoonotic virus. That means that the origin of this virus is actually in animals, right? Like, and with coronaviruses, it's specifically bats that we talk about. You just have to understand most of the viruses that we deal with in real life now, they actually are of zoonotic origin, just like HIV, um, and more importantly, influenza. Influenza is actually a bird virus, right? So, and it crosses over into species or causes these spillover events that lead to human epidemics. The last major pandemic that we know of a respiratory virus like this was the 1918 influenza virus pandemic. That was that had the numbers like we are starting to see now. There have been other, H1N1 influenza in 2009 and 10 that we saw, but again, this has not been the same magnitude. And comparing this virus to the influenza virus is also not true. Okay. The most important thing to know about these viruses is they're called coronaviruses because they have these crown-like projections, as we know, right? And they originated in bats. Okay, that there are certain coronaviruses that already circulate in human beings, and in North America, they cause about 15% of common cold-like illness during cold and flu season. There are different kinds of these viruses in bats. There are approximately 40 to 50 known coronaviruses, and this one This particular coronavirus, the SARS-CoV-2, likely jumped from an animal, so from a bat to an animal, then animal to human, somewhere around October 30th or 31st. The first known case now that we know about likely was November 17th in Wuhan, and then it started a cluster, different clusters of infection. The test for this virus became available on January the 3rd. So all of this had to be retrospective diagnosis, right? And then it just exploded. Initially, the thought was that this is all related to the seafood or the wild food wholesale market, where there is a lot of different species are in very close contact, right? So I mean, it's like Machli Bazaar times 1,000, right? Like it's so many people, so many animals in such a close contact, and that was the thought was that this there was likely an epidemiologic link to that market. Well, this has been thought not to be true. Uh, it's just it came to light through that market, and that market was shut down on January the 1st. I still remember on December 31st when there was an email sent out by ProMed Mail um, about an unusual cluster of pneumonia in Wuhan in China, and at that time they were trying to rule out other viruses like SARS virus that we saw in 2003 and 4, or high pathogenicity influenza virus at that time. Once all of these were ruled out, they then named it novel coronavirus, and they started looking for the viral sequences. On January 7th, they finally posted the viral sequence online. Okay. Um, Today we stand at upwards of 3 million cases worldwide now, with more than a million in United States, right? So 1/3 of the cases in the world are actually in United States. Um, Here, where we are in Canada, this has led to a lot of disruption in daily life, as it has in Pakistan and other countries
Hmm.
all around the world. More than 95% of world population is under lockdown right now, right? So this is unprecedented. Like nobody thought that this would be the case. How did we get here? Um, Somebody it's very difficult to say, right? Like as global warming, as human animal interaction progresses, the chances of spillover events are higher. And they actually looked back when the SARS epidemic arose in 2003 and 4. They actually looked back and did a serological study about coronaviruses looked at antibodies against coronaviruses in a population in southern China, and they found about 3% of people had antibodies to novel coronaviruses. Okay, and so that means more these spillover events occur more frequently. We just don't know about them. Okay, this is very important to know because there is something different about this virus that led to this explosive chain of infection, and um, that has led to this much disruption and death. Okay, I'm going to stop here and see what else we can talk about, or if somebody has
I
a question about it.
wanted to ask you, okay, is it a different strain or is it a mutation in the same virus?
So coronaviruses, right, like are a large family of viruses. Okay,
Yeah, yeah.
and they are divided into alpha, beta, gamma, and delta coronaviruses. Okay. Um, Within these classes, there are subfamilies, and what actually we worry about are the SARS coronavirus 1, right? Like that led to SARS. And the second is the Middle East respiratory syndrome coronavirus, which is
Yeah.
currently floating or currently circulating in camels and with spillover event into humans. Again, that virus is also originated in the bat, from bat to camel, and it's essentially a common cold virus in bats. Okay, this particular virus is 85 or 86% similar to SARS coronavirus 1,
Okay.
but genetically still quite different. Okay,
All right.
so we can't say that this is a mutated virus. It's just in the same family of viruses. It just spilled over now.
Okay. And can you kind of like outline the clinical presentation that that you see commonly? How is it different from other viruses, yeah, other common cold and flu and stuff like that?
Okay, so what we have seen here is this with this virus, right? Like initially the thought was this is a common cold virus, right? Like nazla, zukam, khasi, and you're done with it.
Yeah.
It's still true for more than 90% of people, right? And um, there has been multiple different symptoms that have now been attributed to it. So going from head to toe, I'll let Rizwan talk about the neurological stuff, but going through head to toe, anosmia, runny nose, coryza, even conjunctivitis, right? Like so red eyes, and then sore throat. In some people, it actually progresses to pneumonia. And what we have seen patients here describe is Jalan, like so very different than heartburn. They actually say our lungs are on fire. Okay, so
Okay.
very inflamed. They have difficulty breathing, right? Like so dyspneic. Um, GI symptoms, and the pathophysiology behind that is the ACE2 receptors that we will talk about later too. And these ACE2 receptors that this virus binds to are also present not only in higher concentration in the nose and upper respiratory tract, they're actually much higher concentration in the GI tract too. So people have been presenting with diarrhea, right? Um, and more than more than influenza, they actually, influenza, we know there is a lot of body aches and pains, but this is out of proportion in this too, headaches and body aches and pains with this. So essentially, this is what gives this virus an evolutionary advantage.
Mhm.
Its symptoms are just like anything else. And allergies, right? Like this allergy season, like, we would have people who you would write off as allergy, but
Yeah.
now you have to be so thoughtful and, you know, diagnose it to control it properly.
Yeah.
So,
Okay.
Rizwan, I'd like to have your thoughts and your feedback on the neurological symptoms of patients having COVID-19.
Yeah, thank you. So Karim fantastically gave a great thing about the history and the other symptoms like respiratory symptoms and GI symptoms. So that's important. I just want to tell, because physicians are, we have general practitioners, internal medicine colleagues of ours who are kind of dealing with this pandemic. So the typical patient that you're kind of on the lookout for is your typical patient who walks in with a flu, with a fever, with a cough, or shortness of breath, and everyone is like, waiting for that patient. So when you hear of that patient coming in, you'll get prepared. You'll wear PPE, you'll take precautions and everything. But what happens when you have a patient that comes in that doesn't have those typical symptoms? And that's kind of the problem. So for those who are interested, there was a very good article in JAMA that came out in about April of this year from Wuhan, China, where the outbreak started. And what they looked at was patients who came with neurological symptoms. And they saw that about 36% of those patients that presented with different neurological symptoms did not have signs of COVID-19. So they were not short of breath, did not have any respiratory issues, no fever, no cough. And what happens with that is let's say, I deal mostly with strokes. So you have a stroke patient that comes to the emergency room, or you have a patient with GBS. The provider taking care of that patient in the emergency room or the general practitioner is not going to suspect COVID-19. But then when you start treating that patient, eventually after a few days, that patient starts developing a fever, a cough, and they're like, oh my God, let me check for COVID-19. And then it comes out positive. But during that time, from the minute that patient walked into the hospital, to the staff in the emergency room, to the nursing staff taking care of that patient, or if you're in an academic program, residents, fellows getting exposed to that patient, are now all have to be quarantined. So that was an interesting paper that said about 36% of patients from about a group of 200 people that they looked into had just neurological symptoms. And I'll walk through some of the symptoms that they saw, because those are symptoms that I would never have thought. So the basic symptom that people would complain would be like dizziness and headache. That would just be a general symptom that people would come in with. Some would have this impaired consciousness leading to like a delirium. So normally we see ICU-induced delirium in patients who've been in the ICU for a few days. But these were patients who were at home and were coming into the hospital, and within a day were like hallucinating, and slowly they would become stuporous, they would become somnolent and go into a coma. So that was one thing that was like very generalized, symptomatology that was seen in it. They didn't have a cough, they didn't have a fever.
So are you seeing patients with COVID-19 having strokes as well?
Yeah. So I'll talk about that in a little detail in a bit. But initially, and I think Tajammul last week when he was talking about stroke. So initially, when the pandemic came in New York, or even I'm in Philadelphia, we're like 90 minutes away from New York and just 10 minutes away from Jersey. So these are like really hard centers for COVID-19. We didn't see any strokes, no heart attacks coming to the hospital. And it doesn't make sense, because why would somebody stop having a heart attack? Why would somebody stop having a stroke? It does. My wife was asking me what's happening. Why aren't you so busy? Like your phone would go off every night, like about 20 times. And now you're just having one call, you're sleeping through the night, nothing's happening. So we were all, surprised. And then we, found out across the country that's kind of a trend. And I'll tell you an interesting story. So we got a call for a stroke evaluation in the emergency room. And my resident went and saw the patient, and we were confused if this patient had an acute stroke, because you want to give them TPA if they're in the first 1 hour window. But that patient was really altered, could not speak. So I told the resident, why don't you examine the patient, get ready. I'll go to the waiting room and I'll talk to the family member who bought the patient. Now the waiting room, as you know, in Pakistan, 100 people waiting, families, people waiting to get into the ER, get evaluated. When I walked over there was just one attendant who was with the patient. I was the only person over there, and nobody else was there. I was like, what's happening over there? So after I got the history and I realized this is not like an acute stroke I could worry about, I asked the security guard, I was like, where is everyone? Have you guys moved to the waiting area somewhere? So he was like, no, ever since we've got about 2 or 3 patients, we're telling the people who are coming in that, we have a few coronavirus patients. So if you want to stay, you're welcome to stay. Otherwise, you can go home. And everybody is going home. No one wants to stay in the ER. So then now what we realized was that people are just not coming. So people are having stroke at home, and they're like, we'll see. It's just my arm that's not moving, or I'll get okay, until they really, really get bad, and then they come. Initially, there was no stroke, no heart attacks, but now we suddenly see the mass in patients coming in with heart attack.
And why do you think that is? Like, why is there sudden, shift in paradigm?
Yeah, so the great question. So like Karim described, the ACE receptor. So the ACE receptor, typically when it's found in your upper respiratory tract, it's also found in the endothelium. So there's a lot of endothelial dysfunction that's happening. So there's release of von Willebrand factor, factor A, that's causing this platelet accumulation, causing thrombus that's formed, and that's going up to the brain and causing these large strokes. Interestingly, talking about New York, there was just a paper that came out a couple of days ago that there were 5 patients less than 50 years of age who presented with like massive stroke. Now, just for people who are not practicing neurology, when you talk about ischemic strokes, I'm not talking about brain hemorrhage. Yeah. Ischemic strokes are those where there are 5 different types, but if I had to divide them into 2 major types, they're your typical large vessel and your small vessel. So from what we study in medical school, your small vessel are those small high blood pressure, diabetes, smokers, where you have these little strokes, and then you have your large vessel. So you'll have a big blood clot that will break off, get stuck in the internal carotid artery or the middle cerebral artery or in the basilar artery, and that requires an intervention. So you go in and do a mechanical thrombectomy and pull the blood clot out. So what we're starting to see is that these young patients, less than 50 years, who are sitting at home just because they don't want to go out, suddenly develop these massive large vessel occlusion strokes. And when they came to the hospital, interestingly, they were getting TPA. And when the interventionalist was putting a catheter in and pulling the blood clot out, he saw the blood clot was forming again, right over there, live in front of his eyes. And he couldn't believe it. He's like, this patient's on TPA, which is a clot busting rate. Why are they so hypercoagulable. And that I think we'll discuss later on, and I'll get Karim's input too.
Just one question कि ये जो patient तुम्हारे पास आ रहे थे, did they have typical symptoms or were they diagnosed already? या ये बिल्कुल they were just normal and then they developed these neurological symptoms?
They were normal at home, normal just like you and me, no cough, no nothing. And suddenly they had this big stroke. The family was like, oh my God, you can't move, you can't speak, got them to the hospital. And then during the hospitalization, they developed a fever and they developed symptoms. And then they were like, okay. And they gave the number. They said on average, we see 0.7 young strokes every 2 weeks. That's young strokes. Now we saw 5 strokes in 2 weeks. And just for people in Pakistan, that, you know, when you talk about 50-year-olds in the US, you're comparing that to about 30 to 40-year-old people in Pakistan. Here, people are very healthy, they're very active, you know, they take good care of themselves. So these are like really young people. So that was very surprising for us. And since you raised the question also, there was a case that I had, a 50-year-old guy who's admitted in the hospital with corona, just wasn't my 2 liters of oxygen. Doing great. Improved, came off, was in room air, ready to go home. The nurse was like, you know, you're ready to get discharged. So he was like, let me call my family and just tell them to pick me up in 30 minutes. So she left the room because he wanted to call his family. And when she went to check back on him in 20 minutes, he had collapsed. The phone was out of his hand. His right side was weak. He was unable to speak. And I remember I was on call, and that was the first patient that we had, corona patient, ready to get discharged, and suddenly had this massive stroke. So we're now seeing this whole shift in this whole prothrombotic state, which is not just related to strokes, but rather like DVTs and PEs, something that we know, but we're seeing more heart attacks all the time. I also want to mention on the topic of neurology that there are other neurological diseases that are now getting worse, or their presentations are like more worse off this whole COVID pandemic. So surprisingly, patients with Parkinson's disease, and I know there will be many physicians in Pakistan taking care of them. So there was a study in UK that looked at 10 patients with Parkinson's, and they saw that there was a 40% mortality in these patients because when they had COVID-19 infection. And that was surprising. Why would a patient with Parkinson's, and these were patients who had advanced Parkinson's disease for more than 10 years, who were on levodopa infusions or had a deep brain stimulation, they were dying. So they figured out 2 reasons. One is that they required increased doses of levodopa because of respiratory muscle rigidity. They required more of those doses to help them breathe. And these patients have decreased respiratory reserve. And the second effect was because of this whole concept of social distance. These people were at home, they're elderly, they're unable to get timely care, they're unable to go to their GP, get their levodopa doses titrated. So they saw that this is like 40% of the people are dying just because of this whole social distance. So that I thought was very interesting. Another thing that people might see in the community is GBS, so Guillain-Barré syndrome. We know, we studied in medical school that if somebody comes with GBS, asks about Campylobacter jejuni infection 2 weeks ago or EBV infection, we know that in the Zika virus, that people would have the virus and then 2-3 weeks later they would have GBS. The problem with COVID is that it's not a post-infection, it's a para-infection, the neurotropic virus. So people can present with your typical ascending weakness, which is GBS. And again, the healthcare worker is exposed, and then these patients later develop signs of COVID. Also, what's interesting is that GBS itself affects the breathing. So these patients might get intubated, might go on a ventilator, and you never know it's because of the GBS or it's because of this whole COVID respiratory failure that's happening. And some people have also looked into patients having seizures or brainstem disease. And before I conclude, I just want to say in terms of brainstem disease, this is very important for the intensivist. So there's a debate that the virus moves from your chemo and mechanical receptors in your lungs through the synapse and the neurons to the cardiorespiratory symptoms in the lower medulla, in brainstem, and they've seen like severe infection, severe brainstem infection, and that affects. When it affects the respiratory center, these patients don't have their normal breathing pushed. So if they're intubated and on the ventilator, the intensivist will be like, oh my God, I fixed his COVID, his lungs look great, why can't I remove him from the vent? It's because they're losing that respiratory drive. So if you have a patient like that, it's very important that you do an MRI of the brainstem, or you do some CSF testing to see their neurological infections causing that respiratory failure. Just a fun fact out there for medical students or young graduates. In medical school, we used to hear about the Ondine's curse. This was a guy who fell in love with a girl, and the king cursed the guy, put an Ondine's curse on him. So he had to remember to do everything. And he also had to remember to breathe. So when he went to bed, he forgot to breathe and he died. So that Ondine's curse is when people have strokes in that lower medullary area, where actually the COVID virus goes. So that's something that we.
Yeah. Thank you, Rizwan, for such an elaborate neurological, summary of what you should look for. Karim, can you please tell us about the diagnosis? How do you diagnose the disease?
I see a question here from Uwais. Do you want me to address it now or later?
Yes, you
Yeah,
can
you
address now.
Okay, so Uwais is asking about spillage of coronaviruses from animals, so a zoonotic infection. Or what about the other way around, right? Like so, anthropomorphic infection, which means transfer from human to animal. So yeah, goras love their pets here, and there have been cases of certain animals pet situation where they have become infected. So I know about 2 cats in America, right? Rizwan, you may know more about the cats in America. I know the tiger in New York Zoo, and there is also a report coming out about tigers actually in India are becoming infected. We don't know whether it can go from these animals, so feline animals, into humans, and that continues the chain, or it just goes into from the pet owner into the pet, and then it just dies off there. But animals have had very, very mild symptoms at best with this. I hope this answers his question.
Yeah, and now can you elaborate about the diagnosis? Like, how do you
Okay,
diagnose?
so um, there is obviously not going to be a gold standard right at this moment because this is just 3 month old, right? 3 4 month old. But PCR, a nasopharyngeal swab PCR, is what's used for diagnosis. There have been other criteria to diagnose it in resource limited setting or in in places where there have been large scale outbreaks where they don't wait for nasopharyngeal swab. They actually look for um, radiologic signs. So ground glass opacities on CAT scans, right? And an exposure to somebody with an acute respiratory illness or exposure to somebody with confirmed COVID. And here in Canada, we actually made it so in the end that anybody with an exposure to anyone from United States was considered a suspect until there was, because there has been uncontrolled spread in United States, right? Like so until the border was closed, this was also considered a criterion. So short answer, diagnosis is done through uh, PCR, radiologic findings, and people are starting to understand the role of immunoglobulins or immunity, IgG and IgM. But
Yeah.
those are very new tests, not validated. Everybody with a machine has come out with a test. So they need to be validated in order to be understood a little bit better what their role in diagnosis would be. Okay.
So primarily clinical, and then supported by these things that you mentioned.
Yeah.
Yeah. And can you talk about the latest drugs and clinical trials that have been going on? Obviously, we don't
Yes.
have much data because it's a very new disease, but still,
Yep.
if you can kind
Yep.
of.
Yep. So this is very, very important to know because people started running their mouths off about hydroxychloroquine between being the God's gift to mankind, and then people started uh, doing this. Started taking so fish tank cleaners apparently have chloroquine phosphate in them. So some genius took chloroquine phosphate because of the when it was recommended by Dr. Trump. And basically, what happened in the end, they actually ended up, one of them actually died. I can say that because I'm sitting here in Canada. But basically, the issue here, right, like is there are Infectious Disease Society of America guidelines. There is provincial guidelines from Canada now, which we were a part of, that recommend no drug to be used outside of a clinical trial. Okay, the only drug that is actually directed against this virus that we know of, it's called remdesivir, and it has shown some promise in at least one trial in US, but most of the data that came out of Wuhan did not show any benefit. Okay, then there are non-directed or non-virus specific treatments like hydroxychloroquine and chloroquine phosphate and azithromycin, which have immunomodulatory effects. So again, these are being recommended as part of clinical trials, and they are WHO solidarity trials that a lot of international centers are part of. I would also mention one thing is about convalescent plasma that has also received a lot of attention. That data about convalescent plasma actually came out of 1918 pandemic, right?
Yeah.
So there were some cases where they gave convalescent plasma within 5 days of onset of symptoms to some patients, and they improved. And they are starting to look into it. And again, it's going to be studied in trials. So, if you ask me, what would I do for for a single patient that presents or my loved one? I would say, you provide them with the best possible supportive care, right? If there is a secondary bacterial infection, you treat that.
Yeah.
If there is, septic shock, if there is ARDS, you treat accordingly. But specific therapy there is none that has proven any benefit, and it may actually be harmful. So outside of clinical trials, nothing has been approved yet. Okay.
Karim, can you also touch a little bit about this herd immunity and how do you develop immunity to corona, and about that?
So, the best example of this herd immunity trial is Sweden. Okay.
Yeah.
And they thought they are not going to go into lockdown, and they will be okay, because sufficient people will be infected and they will develop herd immunity and they'll be okay. Sweden is now starting to have the highest death rate in Europe. So it just shows you who's the boss here. It's the virus. It's like we just have to respect and learn. The role of immunity, none of the tests for immune globulins, none of the IgG, IgM tests that have been done here have shown any data. And they actually is a disclaimer. Some people started saying they will do IgG, IgM test on physicians, nurses, and then send them back to work. So there is a big disclaimer that says you can't use this to decide that. You can use IgG, IgM to discuss about how much benefit or what the actual epidemiology of the virus looks like, but you can't make it to make clinical decisions to send people back to work. There is a question here. Oh, you're going to read the question? Somebody will?
There is one question regarding immunity. It's not here. I'm just going to ask you. Somebody sent it to me. What do you think about Pakistan being second time exposed to the virus due to low mortalities as opposed to the Western world? Do you think that's possible? It's like a second exposure, and that's what's preventing mortality rates to climb?
That is a very good question. Okay, and I wish I can have a straight answer to this. I would say we just don't know enough about this virus. Okay, one thing I would say is, when you see a mortality rate like this, you have to question how are you making the diagnosis, right? And is the mortality being captured like we would want it to be, right? So we unless we have a sure shot answer about like everybody is being tested appropriately, and we are capturing the mortality rate properly, it would be difficult to answer that, and can't speculate about that.
Okay.
Okay, I want to bring in Rizwan to this comment first. Can we in any way preempt stroke given the prothrombic nature of the disease based on symptoms of signs? So can intervene early and prevent a catastrophe? So you want to comment on?
Yeah, that's a great question. So I just want to take people back just to know that besides the COVID pandemic, there's an interesting article in 2008 New England Journal of Medicine that looked at people who would just have a viral infection. What's the risk of them having a stroke or a heart? And they looked at about 20,000 people in each group, those who got vaccinated and then eventually ended up having like a flu or a UTI. Interestingly, what that study showed was, and this has nothing to do with vaccination, that people with vaccination got a stroke. These are just to make sure that people are immune. So, so these people who actually prevented with influenza or with the flu, and some of them had, a UTI as well on that. These are all patients who were admitted in the hospital, so we have the data. So there was a 4 times increased risk of heart attack and about a roughly 3.9 increased risk of strokes in the first 3 days of that illness. So we do know that viral infections increase the risk of patients having strokes or other vascular diseases. Now, can you preempt a stroke from happening? That's a tough question. It's just like, can you preempt a patient having a DVT or PE? And I'll talk about this in a bit later on about prophylactic anticoagulation. But as of now, because this is all very new, we don't have much information to guide like a primary stroke prevention besides people who have a reason to be like on aspirin or Plavix or one of those treatments. But I want to mention, because Karim spoke a little about some of the drugs. I believe one of the combination pills, I think it was ritonavir or something, they have interactions with Plavix and Brilinta. So it's very important for the treating physician that if you're being treated with one of those medications, there can be a reduced efficacy of Plavix or increase bleeding risk of Brilinta. So there might be many patients in the community who have cardiac stents or for secondary stroke prevention or cardiovascular reductions might be on those antiplatelet agents. So be careful. We have so much data coming out on new treatment. It's very important to look at drug-to-drug interaction and see that someone's not at. You might try to prevent something and cause something else worse.
So basically, there's a strong role of anticoagulants, and people tend to move towards it for the treatment. Right? That's what.
Yeah. So before anticoagulation, I just want to explain this whole thrombotic event that happens. And then I'll take you to why this whole idea of anticoagulation came up. So for those physicians who are treating these patients, there was a very good article in the Lancet, I believe, that looked at patients, those who survived and those who did not survive. And they said, what are the different things, the clinical and the laboratory changes that might happen? So I won't talk about the clinical thing, that's really detailed. But I'll mention a few lab findings that they saw, which was very interesting. So one thing was that baseline lymphocyte count that was significantly higher in people who survived as compared to those who did not survive. And when the lymphocyte count dropped, that is, they had lymphopenia, it would be lowest in the first week, and then it would start to slowly go up in those who survived. Whereas those who died, it would just stay low throughout. Then the all famous that everybody quotes, the D dimer, the high sensitivity troponin I, LDH, interleukin 6. Clearly, there was a graph that went up and up and up and up and up in all those patients who died, as compared to those people who survived. The graph was actually plateaued from the beginning. If you have a level of, like, say, 5, it was 5, 0.6, 0.2, 0.3, and those people did great, they survived. Everyone who died, it went up from 0.5 to 1 to 10, 20, 50, 100, and higher up, and they didn't survive. So we do know that there is this whole underlying prothrombotic state. There's also this concept of age-dependent deficits in T cell and B cell function, so that they say possibly could lead to a deficiency of control of the viral. Also, there was this interesting studies from autopsy that came out from Italy, and they looked at lung findings. And what they saw was that besides all the ARDS findings that you get, the whole inflammation and exudate and everything that you see, they also found polyangiitis. that was small micro vessel thrombi that we've seen. And now people are starting to think that, is there some small vessel thrombotic change that's happening that's causing people to develop this whole underlying vasculopathy? And then eventually these people lead up to ARDS. So who knows? But what we do know, and from the Journal of Thrombosis and Hemostasis, they published this, that with anticoagulation, there is decrease in mortality seen in these patients. And they also looked at, and I don't know much about this, so people who might be like intensivists could say there's an ISTH score for sepsis. If that score is more than 4, they saw that people who got anticoagulation actually fared better off than those people who did not. And again, people who had high D dimers or increased level of von Willebrand factor, they actually did worse. Now, I want to mention, because there are a few studies and because I deal with stroke, about findings of antiphospholipid antibodies in serum. So people say beta-2 glycoprotein 1 was anticardiolipin were high. And we know that people who have antiphospholipid antibodies or lupus, patients who develop those antibodies at increased risk of like venous thrombus, arterial thrombus, strokes, miscarriages. We know that. But it's very important to understand that viral infections cause a temporary rise in those antibodies, especially anticardiolipin. 50% of HIV patients will have those rise in those anticardiolipin antibodies, 20% of patients with Hep B, Hep C, and this is a transient thing that resolves within 12 weeks. So there was a paper I was reading that actually said that, patients with antiphospholipid antibodies are coming, they're positive. So don't, take that with a grain of salt. Don't just take everything that comes out. We know that comes up in patients who have a viral infection. There's no reason why COVID should be any. So based on those anecdotal findings and autopsy results, and the single-centered or multi-center experiences that people have had at anticoagulation work, there's this whole trend that people have now started to prophylactically anticoagulate. And every center has their own experience. So if people are interested, you can go to any website online, and you want to go to the Harvard website or Penn website and look at their protocols for anticoagulation. You're happy to do so. Many centers have established their own. I don't know how they're doing it in Pakistan, but there's a general trend that heparins, they bind tightly to these COVID-19 spike proteins, and they down-regulate interleukin-6 and therefore dampen this immune activation. So therefore, heparins are the go-to choice, like low molecular weight heparin or a heparin drip initially. And they didn't see that benefit in DOACs, like Rizwan. So it's important that people, have their whole institutions develop this protocol for early anticoagulation. And then, everyone has a different way. They want to continue it after discharge. At my hospital, normally people send patients out for a month on low molecular heparin. And depending on other factors, like if they have a stroke or a heart attack, they want to continue it longer for like AFib, then those are different scenarios. You might tweak it a bit. But yes, there is now more rationale coming out for early anticoagulation, which could actually indirectly benefit or preempt strokes from happening, just like one of those questions had come up early on. But who knows?
All right. So, Karim, we have a couple of questions for you. Uh, uh, Someone's asking, are you using steroids in your patients, especially in ARDS patients?
So we do not give steroids specifically because they have ARDS due to COVID-19. So if somebody has underlying chronic obstructive airways disease, underlying reason to give them steroids, we give them the steroids, but we generally discourage giving steroids just based on the fact that they are highly inflamed and with COVID. And most of it has to do with, we just don't know how bad people are going to do. We just don't know about this virus that much. There is another question here, right, like about tocilizumab.
Yeah.
Yes, we have used it, but again, it is used in clinical trials, not outside of clinical trials.
Okay. And there's another question about patients who have already had corona infection. Do they get reinfection? Do they develop immunity, or there are chances of reinfection in them?
Okay, so the short answer to this is we have no clue what
Yeah.
happens. Okay, from prior coronaviruses. So if you look at other coronaviruses, you can be reinfected with them. Okay, with this virus, we just don't have that information. There is a case series out of South Korea, right? Like recently that led to this, like, oh, people are being reinfected. The thing is, they are diagnosing or making a call based on a PCR. And you and I know, right, like PCR is highly sensitive, so it even picks up dead viral fragments. So you just don't know if this is actually live virus or dead virus that you're picking up.
Yeah.
So talking about immunity, like antibodies, presence of IgG and IgM, whether it confers immunity, we don't know.
So I have a question for Karim. So when you say that the PCR picks up virus fragments, you're trying to say that somebody could have had the coronavirus at some point, is perfectly fine, and now could still be PCR positive?
Yeah.
Yes. So there is actually, this is a very good question, because we kept getting asked that question, especially about physicians and nurses who have been positive, right? I actually have one physician here who has been positive for 48 days with his PCR. Okay. But there is you have to use clinical judgment, right? Like they're asymptomatic and we just, keep sticking the Q-tip up their nose to find the virus. There is a small paper out of Germany where they looked at this virus, right? Like, so basically they followed serial viral PCRs and they tried to grow the virus. Okay. What they found is, regardless of if your PCR is positive after 6 to 8 days of infection, you just can't grow this virus in cultures. So this just leads credence to this thought that you're just picking up dead viral RNA fragments rather than actual live virus that would lead to an infection.
So I have a question for you, Rizwan. Is there any role of alternate medicine? Like in Pakistan, many people believe that garlic and kalonji has a role in prevention because of its anti-platelet properties. So
Yeah.
does it
Rajit.
I don't know. I don't know if somebody read my mind or something, but 2 weeks ago, my sister called me and she said, "Okay, I have a sore throat and I don't have fever." And I told her that, after 20 years of medical education, my recommendation you is thoda sa garam pani, thodi si shahad. so, so see, I'm not a person who's totally against all this alternative therapy. I'll just tell you this, that we live in the era of evidence-based medicine. And every data that we give or we provide to our physicians comes with like a comparative group. So one person gets it, the other person doesn't get it, and you look at the other. Unfortunately, for all these other alternative treatments, we don't know whether we do know they work, but we just don't know how good they are. So we've seen people like, people with a cold or cough, when we were growing up, that's what we grew up on. Besides antibiotics, all these jari bootia and all these things, oil and all that.
We
And
grew
we
up
were
on
fine.
garlic.
Exactly, and we were fine. Exactly. So there's no harm in taking that unless you're going and getting a prescription from some hakim who you don't know what they're putting in, like steroids or something. Remedies. There's no harm in it. If it helps you, great, just do it. But if you're having a stroke, if you're having a heart attack, or if you have some major problems, then get to a physician. Don't rely on these home remedies.
Yeah, Karim would like to add some.
Rizwan, this Amil Baba in Sadr, it really works. You have, but so it's a very interesting question, right? Like, and jokes aside, there is actually very fanatical belief by some people here where they want to use vitamin C, IV
Yeah.
vitamin C for the treatment of this. Okay, you and I know what vitamin C, like Dr. Irfan Ahmad Khan used to say, "We peshab mein nikal jayega." There is nothing that's going to happen. Just take as much as you want.
Yeah.
So people like when we started questioning them about the vitamin C and ARDS due to COVID, like they actually started talking about, oh, you guys are being negligent. You don't believe in this. It's just, it's hard to explain sometimes beyond this emotional reaction, because we really want to do something for a patient. That you are going to pee out the excess vitamin C anyways. So take it if you want. It's just, you have to know what you're getting, like Rizwan was saying, as opposed to going to somebody where you just don't know, pata nahi kya dal ke de diya, right?
Yeah.
I think beside taking these remedies, one need to ensure that you have to do all the precautionary stuff along. You don't have to
Exactly.
leave them
That's the
visit.
only way. Yep. The SARS epidemic, right? Like during 2003 and 4, there was no fancy antiviral drug or antibiotic. It was hand washing and infection prevention and control measures that controlled it, nothing else.
Yeah, that's what the
They,
Jamal was reiterating in the last session, that this is what you primarily need to do. That's what you need to do, because that's going to save you from getting the infection.
yep, you have to tell people in 2020 to wash your hands.
Yeah.
Mehernosh from my batch is asking a question, right?
Yeah,
So,
the last.
Mehernosh, hi, if you can see me, but so this lopinavir, ritonavir, right, like Kaletra that Rizwan also alluded to. So, experience not outside of clinical trial. There is one clinical trial that actually showed that lopinavir, ritonavir doesn't do anything, and it may actually harm by causing significant drug-drug interactions. So it's going to be studied as part of a large clinical trial. We just don't know about this.
Rizwan, you want to answer this comment of using plasma from recovered patients in treating COVID-19 patients?
I think Karim touched base on that, about that we still don't know. But if I think Karim, if he wants to add something to that, I mean, it's just in the early stages. There's nothing definitive that we know so far. People have improved, but then I've seen people also die. I've heard reports, I've not seen, within the first 10 minutes of infusion. People just
Yeah.
had an anaphylactic reaction and died. So who knows?
The clinical trials that are going to take into account these patients will take in patients who are within 5 days of onset of symptoms and not in ICUs with ARDS, because if they are going to die with this plasma, you just want to make sure, like, you're giving them a treatment that may be harmful. So you're doing this on ward patients as opposed to ICU patients. So just like, again, like, it's clinical trials, not a lot of data yet.
Yeah. Here's another question for you, Rizwan. You would like to answer. Efficacy of TPA in stroke in a corona patient as compared to a patient without it. Any difference witnessed in the efficacy, and what is the protocol followed at your end?
Yeah, the general protocol for stroke is the same. So if we have a stroke patient, we now treat the patient as a patient under investigation, so PUI, because of reasons I mentioned earlier, that you don't know if they have COVID or not. Maybe that's the first presenting symptom of the virus. So everyone's protected. TPA, mechanical thrombectomy, standard of care. We do that. I haven't seen any change in efficacy at my center, but I was mentioning the study in New York where they mentioned that the patient had got TPA, and as they were trying to pull the blood clot out, the large vessel occlusion, they saw the clot was forming again. So it would be interesting going forward to see how many centers report on that. From a neurological perspective, there now every data that's coming out, this is all single center observational studies. It's hard to establish causality across the board. So, it doesn't mean that every patient comes with stroke has COVID until proven otherwise. So we have to be careful. But there's now a database that's been established where everybody puts in their experience with these neurological symptoms and sees how many of those patients had COVID. So I'm guessing that maybe a year down the line, when people look at the frequency, then you can say, okay, these things were mostly associated with COVID, or these are just some random uh, associations that we saw, some confounders that we saw just because of the pandemic. So hard to tell. But yeah, treatment of care for stroke is the same. No changes that we see.
Um, Karim, I would like to have you answer this concern for frontline workers. What would and how much of social distancing would you recommend from their family members living in the same house?
So, we thought a lot about this before, and I know there has been a lot of emotional talk about this from nurses, right? Nursing staff and physicians too. But look, this is a pandemic, okay? And what we know about pandemics is they don't last 2 weeks, 3 weeks, 4 weeks, or a couple of months. We are going to be in this over the next 2 years, okay? And the most important aspect, like, to understand about a pandemic is that everybody is susceptible, right? Like, so the way you define a pandemic is there is widespread local transmission everywhere, and everybody is susceptible because nobody has any immunity to it. You have to make this decision for yourself, right? Like, so what I do, right? We wear scrubs in the hospital, and when we are going home, we change, make sure we wash our hands. My daughter, when she wants to, like, as soon as I enter the house, she wants to come and hug me or give a high five or something. You just stop there, you go take a shower, and then you mingle. As long as you take care of these things, like, because this is not going to be practical, we need to have that emotional connection with our families too, recognizing that the worry is like, what if I give it to my loved ones, right? I just, like, so the recommended physical distancing, right? Like the specific question, kitna dur? It's 6 feet or 2 meters, right?
Yeah.
And in a densely populated area like ours, right? Like, it's very, very difficult to practice, but that is the reason for lockdowns.
All right. So somebody also asked that if the patient is asymptomatic but is corona positive, do they still spread infection?
Yes, the short answer to this is yes. Okay, and it's actually a very interesting question because there has been a lot of debate about this, questions about this. The thought is you have to understand what is asymptomatic and what is pre-symptomatic, right? So you're catching people early. What they know about this virus now, like that paper that came out of Wuhan, that Rizwan was mentioning too, looked at the RNA levels in the in the nose, basically. And what they found is the RNA levels are actually highest about 24, 48 hours before the onset of symptoms. So that's how the virus will survive and spread, right? Like, it's this is why viruses like rabies, viruses like HIV and all can survive, because you transmit it before becoming symptomatic. That's an evolutionary advantage. With SARS, the first SARS virus, it was so rapid and deadly, right? Like, you just, like, it's not an evolutionary advantage of a virus to be this deadly. Ebola, right? Like, different virus, but comparison is this, like, to compare, okay, a deadly virus, it will just run out of people to kill. So this virus has an evolutionary advantage that you are more infectious in the asymptomatic or pre-symptomatic period than you are in the symptomatic.
So you're saying that every patient who has the virus will eventually develop symptoms, some kind, mild, or they might go on to.
We don't know if that is true. Okay, and so a diagnosis, or if you call somebody pre-symptomatic, it has to be a retrospective diagnosis, right? You
Yeah.
just follow people, like a group of people who have been exposed, and it has been shown that about 5 to 6% of people will be asymptomatic or minimum symptoms. Just a tickle in my throat and I'm fine, right? Like,
Yeah.
2 din ke baad I'm fine. So
Yeah.
those people have also transmitted the virus. This is why the numbers are so high.
Can you tell me about the mortality uh, in your part of your region? What is it like due to corona?
So Rizwan, do you want to start, or?
Yeah, sure. So it varies by region. So New York has, some people reported a 4 to 5% mortality. In Pennsylvania, so we have like a 7 hospital system that we are part of. And one of the hospitals is in New Jersey. So interestingly, that one hospital in New Jersey has a lot of nursing homes around it. So they had like 200 patients at one time admitted. Of those, 150 were on the vent. As compared to in downtown Philly, where I am, we have like about 50 patients, maybe 10 on the vent at one point. So it's very variable. It depends. If you look at the states like New York or Washington, the West Coast, LA, the mortality is high. Compared to Pakistan, it's different. So hard to put like a figure there out, that this is the mortality, or uh, if you get it, this is the likelihood that you will die. It's hard to say. I'm not sure how it is in Canada.
So I was just wondering, is there a reason for mortality to be high in some part of the world as compared to the other? There could be a reason for it. I'm just like thinking aloud.
So, can I answer?
Yeah,
Yeah.
yeah,
Yeah.
sure.
So mortality is very variable, right? And the issue here is, when we first started looking at United States data, okay, you have to understand the whole country of United States. I think the population is 360, 400 million, something like that, right? Um, and the whole population in Canada is 36 million. Okay, out of those 36 million in the province of Ontario, where we are, we have 10, 12 million people or so. Okay, in the first 2 weeks of this, so February, when everything was starting to ramp up, the the province of Ontario, just our province here, did more tests on people than the whole of United States. Okay, so when we looked at that mortality, we like the biggest worry was they haven't tested enough people. Okay, so there is this pseudo high mortality that you see initially because you haven't tested enough people. Okay, the mortality rate anyway, it ranges anywhere from 0.3 to 0.4% to up to about 2 3 4%. Okay, but it's mostly around 1% or so. Where we are here, we do have higher mortality because of nursing homes, right? Sari victim hamari jo hai na, like they have fallen in nursing homes basically. That's because of older age, right? Like 90-year-olds who don't have the same reserve, same fighting capacity as a 20 or 30-year-old would have. We have had people who have actually been successfully taken off the ventilator and walked home too, but mortality overall is about 0.3, 0.4% to up to 3 or 4%.
I would like to ask Karim and Rizwan, both of you. Now, recently, a lot of autopsies are taking place for this COVID-19, dead bodies. What's the remarkable and significant data we are getting from the autopsies of these cases? In terms of how the virus is evolving and affecting a human body.
I'll have to look at what are we talking about the autopsy data. Like
I think
like
I think there's recently been a lot of autopsy results, especially from lung pathology or GI pathology, whether I think that's where the question might be stemming from. So I'll tell you that first of all, getting an autopsy on a COVID patient is near to impossible. We just had another
it's
patient.
a big risk. It's a
Yeah,
big risk, right?
we had another patient who actually died of brain hemorrhage, and we did everything to convince our pathologist. And he was like, "There's no way he's going to touch COVID patient and do an autopsy." So most of this data is coming out, some from Italy and some from China. And I think what I had mentioned earlier also, that the interesting thing is these micro thrombi that have been found in the small microvasculature, that people are now trying to suggest that this is more of like the whole process is actually an underlying DIC kind of picture, where they're now trying to favor early anticoagulation for all these patients starting off. So I think that's what the autopsy results have suggested so far. There was an article also about looking at autopsies in the small bowel and the large bowel. I haven't read that in detail yet, but kind of it's a matter of time. Slow and steady, we're going to find more things. But like Karim mentioned initially also, it's ACE2 receptor. Wherever the ACE2 receptor is, you're going to have the virus. So if it's it's in high concentration in your nasal passage, you'll have passage of that virus through that and cause loss of smell. As it starts to go down into other areas, you're going to have symptoms from there. But also remember that it's not always that just because you have the ACE receptor that it's likelihood that it's going to go through that and infect that organ system. So there's this whole concept of disseminated transmission through the blood itself that the virus gets to other areas. So who knows? When you look at these autopsy results, like, is it just a respiratory thing that is now just like sepsis? The source is a bacterial pneumonia, but now the patient's septic. It's everywhere. You have kidney failure. You have
multi-organ failure.
respiratory failure, all those things. So who knows? But we'll see as more autopsy results come out. But the microthrombi is kind of what people are trying to put more focus on.
Like you were saying, just like sepsis, right? Like microthrombotic events, right? Like
right.
Just yeah. Somebody asked a question, Huda, earlier, a few questions, right?
Yeah. I wanted to ask you about the, I don't know, I asked it from September also, but he didn't have a concrete answer. I wanted to ask you about the viral load. Does it have any role in, telling you about the symptoms, whether, or the
You
recovery,
asked a question, Huda, earlier.
whether it's going to, does it play a role in recovery or telling you about the symptoms, how it's going to, how the patient is going to behave?
So you're asking about quantitative viral load?
Yes.
I don't think that has been studied. Okay, but if you look at other respiratory viruses, I don't think it would have any bearing on viral load like it does in hepatitis C and hepatitis B or HIV, right? Other chronic viruses. Just don't know about the acute viruses. What role would a quantitative RNA level would play?
Oh, all right. So there was somebody was asking about the vitamin D consumption to boost immunity. Karim, it's directed at
Yes,
you.
Sarah. Hey, Sarah. Hi. It's the like so. Yeah. Every time something new comes up, vitamin D rears its head, right? Like so. Yes, people have fanatical beliefs here about about vitamin D, but nothing direct, nothing specific that has been shown. And I'm not even sure if it's being studied in any trials. But again, there are more meta-analyses about this than there is actual data about vitamin D in COVID-19.
All right. And somebody asked about the children. Are they getting infections at the similar rate and intensity?
So,
Yeah.
so there was some very promising data that has initially come out of China, that there was a large case series of children and everybody thought, perfect, they're all going to do well because, like upwards, if I'm not mistaken, there was about 2,800 children in there and no serious complications, nothing serious happened. That all was fine and dandy up until a week ago when in UK there was a report about this severe inflammatory syndrome and Kawasaki like disease that has been now reported in children. We haven't seen it in Canada, but it is starting to be reported in US now. Most children, like with Kawasaki, like it's a serious illness, but they do okay with aspirin and immune globulins. Okay. But yeah, like there is something more that is coming up.
Yeah, also on a note to that, I just saw somebody had asked a question a while ago about GBS and role of treatment, if there's any change with COVID. No change. So immunoglobulins, IVIGs, and if that doesn't work, then plasmapheresis is the go-to thing. And interestingly, you mentioned about Kawasaki also, so I wonder if IVIGs have a role.
Yep.
Rizwan, there was a question directed at you before about young age and neurological manifestation. I think you mentioned it before also, but I would like you to reiterate on that. Have you witnessed it or in any other states also, or is it more likely manifesting in the older age?
Yeah, so we spoke about young strokes, and I won't go into detail on that. But I want to say that there in one paper they saw that 60 to 70% of patients had loss of smell. And again, because the SARS-2 virus is highly present over there, so it passes through the tubiform plate, can affect the olfactory bulbs, and actually can get to the brain also through that place. I know this one hospital on the West Coast that's now screening their own physicians or their staff as they come in just by their sense of smell. And I tell you, and I tell you this: I know we all do the neuro exam in medical school and nobody wants to check for sensation. But I'll tell you this, whenever somebody has a loss of sensation, the only thing, probably the only thing they're going to complain of is that things taste differently. So if somebody that you know and somebody in the house says that, the food doesn't taste right, no, my taste is gone, always check the sense of smell, because that's going to be the first thing. No one's going to say, I smell bad. Okay, so that would be the first thing that you should check. The second thing is, when it comes to young people, we've seen people having this hemorrhagic encephalopathy or a meningoencephalitis. So we've had young 19-year-old patients in case reports who present, especially on the West Coast, where they had fever, stiff neck, they were checked for COVID, they didn't have respiratory symptoms. And then finally, when they started treating them, then 3, 4, 5 days later, they started developing the typical COVID. So yeah, in young people, we are seeing meningoencephalitis, anosmia, hypoosmia, and stroke. So yeah, those are happening.
All right. And there's another question. Perhaps Karim would like to answer. Any extraordinary precautions for oncological patients in this COVID era?
Okay, so so pandemic, right? Like going back to pandemic, everyone is susceptible. Okay, we don't know, but what we know is everybody, and the mortality rate and all is similar in oncological patients and all. But one interesting thing that has come out is they shed the virus, live virus, for longer and with much more intensity than other people that are not immunocompromised. Okay, um, it's going to be determined in the next few months as we see this spread further and further in human population as to how active chemotherapy, etc., affects this virus. There is a role though where we have started swabbing people before giving them highly toxic chemotherapy, highly suppressive chemotherapy, especially in AML cases and all, where you have to be extra precautious. And if they have evidence of COVID, you delay the treatment as long as you can.
And we have another question. Have they opened up Canadian hospitals for elective procedures?
Not yet. So there is going to be phased. So like Rizwan was saying before, right? Like yahan pe, like it's previously, like it's a publicly funded healthcare system here in Canada, right? So government pays for your treatment. Everybody gets the same level of treatment. So usually emergency rooms and all, right? Like they are like a war zone. There are so many people coming in to get checked and all. As soon as it started happening we started admitting people with coronavirus, the numbers just started dropping. Okay, and then as part of the strategy to limit spread in healthcare facilities, all elective surgeries were canceled here because so as to limit the spread and prepare the system for the surge of patients that may come in because of that. Okay. At the same time, to control the surge, there was physical distancing and shutdown and lockdown was also put in place out in the community. Now that we have started to flatten the curve, there is talk about slow and phased reopening of the economy and of the elective surgeries. How does it look like? Nobody knows. Okay, and we would look to US, like how they are doing things, and we won't do them, right? Like we'll take them as an example of how not to do things and how not to just open up everything at once, because a lot of people are going to die. Short answer to this is we haven't opened up, but there will be a gradual, slow opening up of this over the coming weeks to months.
I also want to add that even here, many elective procedures have shut down. Even clinics are now all on telemedicine that we're conducting. But I also want to mention the second curve that nobody talks about. So your diabetic patient, your patient who has heart failure, who's sitting at home, or your typical medicine patient who's not now coming up, they're not following up in clinic, expect that at some point those patients are now going to have develop their own complications. Expect that surge to slowly start coming.
There will be a high incidence of cirrhosis after this, is the thought, because people are just sitting home drinking now.
Okay, so we have a question. What kind of testing is available in the hospitals, and what are the turnaround time of the test?
Are they talking about? Do we know if they're talking about in general or?
I think they were talking about in general. They didn't specify.
I think the COVID test, if somebody comes in and you screen them, how long will you get the results that they're COVID positive? I think the PCR, basically. I think that's the question.
It all depends on where you are, right? So there are centers that have a turnaround time of 4 hours because they have in-house testing, and then there is 24 to 48 hours waiting. So until then, we put patients in precautions to make sure when you go see them, you put on a gown, you put on gloves, and you wear a mask and face shield.
So, one more question. Somebody has asked that even if you have been tested negative, can you continue to shed the virus?
Tested negative as in after being positive?
Yes. Yeah.
No, doesn't make sense, right?
Yeah.
But if the question is, can you be that episodically the viral? So the this NP swab, it picks up a certain. There has to be a threshold of viral level that it would pick up at, right? Like certain tests are highly sensitive where they pick up like 5 to 10 copies per mil of plasma. But if you don't meet that threshold, or if there is episodic shedding of virus, there may be a point where you may be negative. That's why initially mechanisms that were put in place for people to be called the non-infectious are 2 swabs 24 hours apart, right?
Okay. So, there's a question. How is inter-hospital coordination helping in this?
Okay, so I can answer this like in general, like with us. So where I work, we are spread across a wide swath of wide area, and we have a hospital system comprised of 3 big hospitals with about 900 to 1,000 beds. Okay. We have dedicated one hospital as the COVID-19 hospital, where there is a dedicated ICU unit with a special team that takes care of them, and a ward where these patients come in. Okay. So this is how inter hospital. I mean, we are within the same system. So, but each hospital here is mandated to have capacity and to make sure that you have it. You build up your capacity and do pandemic planning in a way that you're able to take care of a large number of patients.
So, both of you, can you answer this? How are your hospitals managing their clinical staff duty roster and well-being? Have you chalked out system to test doctors and nursing every few weeks?
So we have implemented what's called the active screening at the door. Okay. Basically, what that means is before you come into the hospital, there is a checklist of symptoms, a large number of symptoms that you have to fill in, and then you get clearance, right? Like if you have even minimal symptoms, really, you will not be allowed in the hospital. You will be sent to get tested. Okay. We haven't undertaken asymptomatic healthcare worker swabbing yet, because asymptomatic swabs, I think they don't give you any information, right? Like if it's positive, it may be something, but if it's negative, it doesn't tell you anything, because you may develop symptoms 5 days from now and your viral uh, um, um, threshold would be met like in the next 2 to 3 days. So just based on asymptomatic swabbing, like it's symptom-based screening rather than swab-based screening. Very low threshold actually to test healthcare workers, because outbreaks that we see now in the hospitals, right, like are actually due to healthcare workers not practicing social distancing, right, like break rooms and all, where they meet. And there is a lot of death that you have to deal with. We deal with a very older population here, and it's just it's impossible to have physical distancing. So we have relied on symptom-based screening.
And
And
we have something similar. We have something similar too. So the staff entrance is totally different from your regular, and where people enter is different from where people leave is different. Everybody has to wear a mask now as they enter, and anywhere in the hospital you have to be wearing a mask. You screen with your temperature as you get in. In terms of other staff, so any staff that doesn't need to be in the hospital should not be in the hospital. So if you're not on service, if you're not rounding, then you have to be at home. All our meetings, like our journal club meetings or clinics, they're all on the iPad, so telemedicine, teleneurology. As terms of when it goes to residents, so if the resident is on inpatient service, they're supposed to be there. If they're not, so most of them are now put on elective or just on outpatient, which they deal from their home. So it's basically the only person who really needs to have a patient interaction needs to be in the hospital. No one else is coming in. Also, we get like regular lunch as part of our meeting. So that also used to be like, you have a big box, one large pizza and a whole salad bowl. Everybody's taking from that. So that's also now cut down. Everybody gets their own fixed meal boxes. You take your own meal box and leave. Any way
no
to prevent,
longer.
Yeah, no. No. So anything that prevents transmission. Then when you go to round, only one physician will go see the patient, and only at one point in time. So it's not like the whole team is going in the room. Like the resident will go, then the medical student will go, then the consultant will go. So one person will go, and normally it's the consultant, because the consultant has to see the patient, and the consultant will keep the iPad in the room, and the residents will actually be watching the exam. So now there's a change in how it was before. First, the resident used to go and see the patient, but now the attending is going and seeing the patient. So anything to limit exposure. And I'm talking about the neurology floor. We're not even having COVID patients. And then in the hospital also, and majority of hospitals have done this, that they've made a COVID unit that's totally isolated or totally separate. So you won't have a COVID floor within one other floor. So we have 7 towers. One tower is like floor 1 to floor 7 is all COVID. So you have the COVID ICU in that, you have the COVID step down in that, you have the COVID general floor on that, and everything else is also separate. So that's why, just to limit exposure. And also, the good thing that the hospital did was that they don't want us to take public transport anymore. So for those who drive, the garage parkings have been made free. The area around the hospital, parking is now not being charged anymore by the city. So people want to park over there. Also, we have the Sheraton that's right behind the hospital. So they're offering free rooms for people, especially in the emergency room, who are doing like long shifts, cannot drive home. So they get free rooms to stay over there. But it's great. So anything to decrease the exposure to.
We have done this here too, where a staff that is working in dedicated COVID units does not go anywhere else in the hospital to work. Right? Like, so that has also been cohorted that way.
All right. So any cases of vertical transmission, what about breast transmission with corona positive?
Yep. So there was a report, and there is now more reports coming out of New York. Yes, there is vertical transmission, but the thing is, neonates and all just do okay. So the recommendation is not to separate them from the mothers. It's there in the breast milk. It's there. It's just, you just don't know what that means because the baby has already been exposed, right? It's more like it's present in almost every bodily fluid.
Okay. Yeah. So do you have residents work 15 days on and then 15 off? And do they stay on campus?
Yeah. Not 15 days on, 15 days off. So what we've done is we never had a night float system. So for those who don't know, night float is like, you normally in Pakistan, we have the resident who comes and does a 36-hour shift.
Yeah.
So we used to have that first, but now that we did a night floor, so there'll be one resident who'll come at in the night and stay till 6 in the morning, and throughout the week they'll do that. So there'll be one resident, excuse me, who does that. And then we've limited the residents, so it's more role for the fellows, more role for the attendings, that they take on the responsibility rather than having a whole crew of like 6 residents around, and you just have now 2 residents around. Also, when it comes to medical students, so there are no more medical students that are coming in. So this is the time where they graduate and they start residency in July. So medical students are all at home, or at some places they've been graduated early, so they can start coming and working as interns before.
What PPE are you using in COVID positive wards without aerosol generating procedure?
So, thank you for asking this question, whoever is asking. Okay, this is, people have wanted spacesuits from the beginning, right? Like, this is, and mostly this was driven out of the fear of unknown, right? But what we know about this virus is it's droplet contact like influenza, right? So pathophysiologic mechanism is similar for transmission. It's just it is highly infectious, so more infectious than influenza. So if we are not doing aerosol generating medical procedures, which is putting somebody on BiPAP or bronching or intubating and extubating, then we wear a gown that is fluid resistant, right? You wear a mask with face shield, so some sort of eye cover, be it goggles or a face shield, and you wear gloves. Okay. And you have to, like, because there was a shortage of PPE, basically because you were in a cohorted unit, all you would do is change your gowns and gloves between patients who are positive for COVID and continue to wear the same mask and the face shield. If you're doing an aerosol generating medical procedure, then you do the N95 mask and an impermeable gown and face shield that way.
So we'll just have a couple of more questions because we're running out of time, and the questions will be on the Facebook live this stream, and both of you can answer specifically on them. This question, can somebody answer? In fact, Karim. Given Canadian healthcare system is state-run, has government been able to become biggest healthcare data aggregator? What is the level of integration and interoperability of data you have observed by the government that is helping them with prediction and planning, or is it yet to happen?
So no, we have actually been ahead of this, and all data is carefully tracked through public health units that are responsible for certain local areas, so local municipalities, right? Like we have the municipality system here, and this data is very dependent on public health units reporting. There is standardized forms that public health units fill out, and this is the same form that WHO uses for their pandemics, right? So all of this data is standardized that way. And there is registry level data now at academic centers and larger community hospital systems like we have, where we take into account all these and then just keep adding more and more. There are some centers that have started saving plasma samples, right? And also other body fluid samples from patients who have recovered, are infected, or have died with this, so that for future, like if we need to study something, then we can use those samples.
Karim, I would like to ask, I know it may be a political question, but is there a mistrust among data coming out from different countries? Like maybe the Canada is not trusting the data that's coming out from Italy, and whether the US is, we agree that we are not trusting the data from China, but is mistrust upon the data is also, affecting the management of this pandemic?
Actually, I would say no. right? Like this has brought out, best in most of the people with data sharing. And very early, like as soon as Italy started seeing its surge, they started sharing data with the physicians here, and started warning, like both in US, in North America, and Canada and Mexico, that look, if you don't prepare, this is what's coming. And the thankful thing was that we actually had time to prepare in Canada, and we listened to WHO, we listened to our peers in not in US, but actually thankfully we didn't listen, but uh, we listened to Italy, right? Like if it wasn't for Italy starting to share its data, like we would have drowned, and we would be in a similar situation that our poor people in New York are. And if this continues this way, like Pakistan and India are now becoming centers where things are starting to ramp up, right? So listening, like I would trust the data that comes out of Canada for sure. WHO, when they say something, right, that is very, very important. And I know Awais had mentioned this before. Like WHO website has a lot of useful information, and that most of the data that we get is either from Johns Hopkins or WHO website that way. So I would
Okay.
trust them.
Yeah. So, Rizwan, can you please summarize COVID-related neurological manifestations and treatment? Basically, a nutshell of today's talk.
Nutshell of today's talk. That's the whole talk, or half the talk.
Yeah,
So I
somebody
think I think
asked again. Yeah.
so. I think the take-home message from a neurological standpoint is that if somebody comes in with neuro symptoms, keep COVID at the back of. Don't go crazy testing everyone, but keep it that maybe that's the initial presentation. Young strokes, GBS, seizures, muscle injury, Parkinson's patients that are deteriorating, um, and anosmia, hypoosmia, seizures, hemorrhagic encephalopathy, just to name a few. And also, I didn't talk about brain hemorrhage, but we talk about DIC and traumatic state. 2 days ago, I was on call, and I don't know if Pakistan has ECMO, but we use ECMO a lot in the US, and it's basically VA, VV ECMO. You have to put a catheter, and you put them on some heparin. And these patients actually had a lot of hemorrhages, brain hemorrhages, and 40% mortality was seen. And we don't know why. And these patients were not on like therapeutic doses of heparin. So we actually were publishing that probably in a week or two, but we've changed our guidelines that they should not be on heparin. They should just be on like aspirin and maybe low molecular weight but just neurological symptoms, just like other things, keep it at the back of your mind. Don't take it that these patients will not have COVID, especially for the healthcare professional who might unnecessarily be exposed to COVID-19 and realize that, few days or weeks later.
So, we have another question. Where do you guys see things heading in Pakistan COVID-wise?
Yeah, I think people in Pakistan can answer that better than we over here. From what I hear from family and friends, it's again, like Karim also mentioned, it's the more you test, the more you realize. Unfortunately, different countries have different social, economic factors that you really can't generalize one country to the other. So Pakistan people are more daily wage earners. They have to go to work. We don't have a system where there's a lot of economic, um, you know, improvision, or people like where the government can provide to the people just by sitting at home. So that takes a toll. And like Karim rightly mentioned, that we expect that probably if people continue to not practice social distancing, that the numbers might go up. But that's a double-edged sword, because you're technically saying that I don't want you to come out to work and I want you to be hungry, but I also don't want you to come out and get exposed. So what can you do? It's easy for the people like us to say that, but when you really talk to the masses in Pakistan, it's really hard to kind of justify what we're saying with the problems that they're in.
Yeah. So, just to let people here know about the website or sources of information that people can use to get data or protocols and updates and stuff.
Somebody's asking me about brown ceiling. What does that
Yes.
mean? That means I can't progress because I'm brown. No, I haven't seen that in Canada. No,
Well,
Okay.
we're okay.
I don't know if that's what it means, but neither in the US.
Yeah.
Okay. So just give us the websites or sources of information that
Can I add one thing quickly before? So we were asking, right? Like, what do we see from Pakistan level? And like Rizwan answered it very well. Like, what we see for the world is, with pandemics, eventually what happens is 60 to 70% of population will become infected. So this virus is actually trying to set up itself in the human population so that it will keep on returning as a common cold virus eventually. But before it does that, this pandemic that comes in waves, it comes in 2 or 3 waves. The second wave tends to be the worst, right? So 60% population becoming infected, that means about, if you just take mortality rate as around 1 to 2%, that means about 18 to 20 million people will die. And how quickly this happens is what decides how healthcare systems fail, right? Like, so that's where we talk about flattening the curve. So these lockdown measures and all, and they are easy to do here, but they are not easy to do in countries like India, Pakistan. In Pakistan specifically, where there is like, how is somebody going to feed the family who earns every day, right? Like, who has to make money every day? No answer here.
So just give us
Websites.
websites, and then we'll wrap it up.
WHO, right? So look at WHO website. That's the best. It gives you very good overview of things about what the current epidemiologic status is. And WHO website actually has very interesting courses that that are free that you can do to understand, to study the virus, to practice infection prevention and control. And there is also this thing called the WHO Mythbusters, which I find highly entertaining and very useful. That's where all this garlic piece had come in. Somebody had started, mentioning about drinking Clorox and all bleach, right? Like, so they actually say that, like, please, God, just don't do that. Like, nothing good is going to come out of you drinking Clorox and bleach. And they also talked, like, there was a talk about people rubbing sesame oil, right? Like, so til ka, like oil all over their body to prevent corona from entering. So mythbusters like that are very useful. And Johns Hopkins website tracks all of this in real time, which is very useful. It has graphs that help, and country-specific data that also helps. So these are the two main websites that we look at.
I also want to mention about data, since Karim mentioned a lot about data coming out from everywhere except the US. So I just want to go, at least for the young medical students or the recent graduates who might not remember Irfan Ahmed Khan, who was like a master clinician. We were very fortunate to have a bunch of like physicians who we trained under. And if I start naming all of them from first to final year, it would go on forever. But when we started, and our group was the first 10 people who started in medicine, the first in medicine block in final year, we were also scared of Irfan Ahmed Khan. He wanted to know everything in detail. But what the guy knew was the data. He always knew the latest research. And he would go into morning rounds and people would be scared of him. Oh my God, this guy is going to quote stuff that we also don't know. And I'm talking about the day when you didn't have an iPad or an iPhone in your hand. You knew it. You were reading it. So one day I got impressed too. And I was like, I'm going to go read articles too. And, try to improve my knowledge. So when you go to the article, you go through, it's like an 8-page article. You have the introduction, you have the methods, you have the biostats, and then you have the results. And I was like, I'm not going to read this. So you read that first thing, introduction, conclusion, methods, and that's it. And you're like, okay, I'm done in 2 minutes. But when I came to the US, you start to realize that all those things that you learn in biostat, this is a retrospective study, this is a prospective, these are the biases. You start to analyze the data much more clearly. So like Karim said about remdesivir, that, we just had the latest, data from the US showing some benefit, but China did not show it. So what I would say in terms of data is that learn to analyze the data yourself. Don't listen to whatever somebody tells you. If I tell you something, don't take it for granted. Analyze the data, see is the study really good? Like people quote the p-value. P is like 0.005 significant. But look at the confidence interval. Is it wide? Is it narrow? Is the sample size small? Is it big? Things that we learned back in the day in biostat. So always analyze the data clearly. And then you will start seeing a trend that, everything is not as simple and straightforward as people tell you. If I'm doing a research on a trial for a year, I'm going to try to say it's the best thing out there. But when you look at my data and you realize that, you're like, I don't think so. I think something's not right over here. So that's something that I'll definitely say when it comes to data analysis.
Yeah.
I like this, like just to add to this about WHO very quickly identified, right, like that with this pandemic, there is actually an infodemic that's going on, right? Everybody and their mother has come up, and like Dr. Irfan Ahmad Khan used to say, unka doodh wala and their meter reader, everybody has come out with recommendations about everything. This is the reason I don't have a Facebook account, but you have to be very, very careful as to where you get your information from, right? And you have to look at, like Rizwan, you're saying, like you have to look at it yourself to make sure. Because there was a joke going around because everybody wanted to do a study about everything, and somebody said in COVID-19 patients, blood transfusion raises the level of hemoglobin. So it's going to happen. Like, it's just you have to understand, like, and take what you take from the data, but if you can apply it to the bedside, this is just too early to be confident about this.
Yeah.
Thank you so much, Rizwan and Karim, especially taking out from such a challenging and busy schedule that you work at, and a perspective you've brought in from neurology, Rizwan, that was wonderful for people to understand that let's not ignore other diseases while we have this pandemic. Although you would like to say something, Rizwan, you want to say any last minute note, and Karim?
Yeah, I would just thank both of them for giving such an elaborate and, informative talk, and, educating us regarding two very specific fields. Thank you, guys. I think everybody is like, impressed with the knowledge and how easy you guys made it sound. So if you guys want to add something, it would be a pleasure.
Rizwan, do you want to go?
Sure. I think the data was the most important thing that I think physicians should take up. But I think for all of us, because we're physicians, I think the most important thing is take care of yourself. Eat well, sleep, exercise. Remember, we are at war with something which has happened after restriction, and our families, our relatives, and our patients depend on us. So this is a time to live up to what we've been trained for, interact. I also want to thank you guys for making this amazing interaction between the Ziauddin alumni. Hats off to you guys, full marks. But keep the great work doing. As physicians, we're all equally involved in this. And if there's any way that we can collaborate or assist or learn from each other, we should keep that.
Yeah.
I thank you for saying this. Like it's like this being Doctor's Day, made it specially. What I would say is like in that same vein, like take care of yourself and try to be safe as to the best you can. but more importantly, just understand that it's not just a disease that we fight here, right? Like we are actually fighting the fear more, and it's nobody's fault. Like it's unknown, and it's unknown that makes you irrational sometimes. And the most important thing about this is planning, right? Like, so pandemic planning, trying to just understand, like, feel free to reach out, right? Like Huda and Fahim and Rizwan and all, like everybody we are all connected. Like, feel free to reach out through email to ask a question. And I really, this is the time when I really miss Dr. Irfan Ahmad Khan the most. I don't know how what he would say during this. I hope he's watching us, and I'm pretty sure he's smiling there, thinking like now you deal with something that nobody has dealt with in this generation, and I hope nobody else has to deal with in future generations. Don't eat bats. I know we don't. I'm just saying.
Okay, guys, we're
I
gonna
know we
end.
don't. Yep.
Yeah.
Okay.
I'm gonna end the broadcast by saying this, that our blog we will be publishing a blog where all of our alumni members can post their articles. They can share their thoughts over there. So not everybody is comfortable in coming and asking questions via video conference. So you can post your latest update over there. We will update you on Sunday. So it's gonna be good night from here in Pakistan. Okay.
Thank you.
Take
Love
care. Peace out.
Peace out.